So we first saw what you need to know. Then we applied that, what you need to know in these questions. Let's start learning what we need to do in order to do these questions. Okay, so we're talking about adrenal insufficiency. In adrenal gland, the cortex will be releasing glucocorticoids, mineralocorticoids, and androgens, whereas medulla releases epinephrine. We know that much. Now let's see the classification. Classification of adrenal insufficiency can be done into acute and chronic, or it can be done as primary, secondary, and tertiary. So each thing can be primary, can be acute or chronic, secondary can be acute or chronic, tertiary can be acute or chronic. But you will not generally see that. You will generally see that in the chronic form, where it will be either primary, secondary, or tertiary, or it will be a case of acute adrenal insufficiency that you have to manage inside an ICU or an emergency department setting. So that is how the question will be tested on step 2. Primary adrenal insufficiency, what is happening is that gland is affected itself. The cortex of the gland is affected. So it will result in cessation of production of all glucocorticoids, mineralocorticoids, and androgens. Everything is affected. So it presents more severely, especially if it is acute. So if it is primary acute adrenal insufficiency, it will present quite acutely and quite severely. Secondary insufficiency could be the ACTH from pituitary is low itself, but the gland is not affected. So in this case, RAS is functional, hypothalamus is functional, just the pituitary gland is affected. Whereas in tertiary, only the hypothalamus is affected, pituitary and adrenal gland is normal in case of tertiary. Is primary, secondary, tertiary. Primary gland is affected, secondary pituitary is affected, tertiary hypothalamus is affected. In case of primary, RAS is disrupted. In case of secondary and tertiary, RAS is functional. If the RAS is functional, if you have mineralocorticoids, you will not see a lot of downstream effects that you see in the primary. Meaning, what is the function of mineralocorticoids? You need to know what is mineralocorticoids and what is its function. Mineralocorticoid, basically aldosterone, functions to excrete potassium, retain sodium, retain water, excrete acid. That is the main function of mineralocorticoid. If the mineralocorticoid is gone, if it is primary, then in that patient, what you will see is the patient is suffering from hyperkalemia, hyponatremia, hypotension, and because salt and hypotension is also gone, the patient will be suffering from salt cravings, etc., etc. So these are the symptoms of primary versus these are the symptoms of secondary. Mineralocorticoid is functional in secondary and tertiary, so it presents less severely. Now we are going a little bit off path, but let's go in the right direction. So etiology. What is the etiology for primary adrenal insufficiency? Most commonly, it is the autoimmune destruction of the adrenal gland, which is generally due to antibodies against beta 21 hydroxylase enzyme. Now, this is a new information. You will not get this kind of information in MBOS or in UWorld or in other resources as well. This is specifically from NCBI. So, beta 21 hydroxylase enzyme deficiency. That is what happens in primary adrenal insufficiency. So, you can test for antibodies against these. This is one specific diagnostic test for primary adrenal insufficiency that is not mentioned in UWorld at all. So, this is the advantage that you get. You also get specific information like this, which you need to remember, which will be helpful. And you may be familiar with the 21 hydroxylase deficiency as well. This is a common thing that we see in reproductive system because deficiency of beta 21 hydroxylase generally causes overproduction of the steroid hormones like DHES and testosterone. So it causes virilizations and all sorts of things. So you will see this in context of reproductive system if you have studied that in step 1 first aid. Otherwise, you can also see this in kidney or in case of endocrinology itself, because congenital adrenal hyperplasia is covered in endocrinology. Congenital adrenal hyperplasia is the most common cause of primary in children. You also have to remember this. So these are two things that are specific informations which can be helpful down the line. Other causes of primary adrenal insufficiency could be anything like adrenal hemorrhage, cancer, infections, or drugs. I'm not telling you to remember the drugs. You can keep things like these for last minute. If you have enough time, if you have enough memory, then you may attempt to do something like remembering drugs for specific conditions. Otherwise, this is not much high yield. So, the major cause for primary adrenal insufficiency is autoimmune destruction, which is through 21 beta hydroxylase deficiency antibodies. Second cause is congenital adrenal hyperplasia. Other causes could be infections. Now, in particular infections, HIV, syphilis, and tuberculosis. These are most common. And if you have a question in which they are suggesting tuberculosis, you will be able to guess it based on other clues. So if they give you a primary adrenal insufficiency case and they want you to make a diagnosis of HIV, syphilis, or tuberculosis, then they will give you a specific history. So for HIV, syphilis, they will give you a history of unprotected sexual intercourse, which is high risk, or intravenous drug abuse. In case of tuberculosis, they will give you other clues like incarceration or travel to endemic countries or resident of the endemic countries. That is how you start thinking in the way of examiners. So start interpreting the clues they are giving you throughout the question. That is how you go in the right direction. We talked about primary. Let's talk about secondary adrenal insufficiency. So the most common cause could be infiltrative diseases like sarcoidosis or hemochromatosis, or it could be hemorrhage or infarction of the pituitary, Sheehan syndrome or ischemia of the pituitary. So the patients could be postpartum patients or patients with pituitary tumors. Hemorrhages can also happen in case of pituitary tumors. So if you have a stem that is beginning with a postpartum patient or with a patient with frequent headaches and bitemporal hemianopsia, then you can think of pituitary Sheehan syndrome or you can think of a pituitary tumor, and then it may go on to secondary adrenal insufficiency. Traumatic brain injury can also cause this. Tertiary is most commonly due to exogenous steroids, and then it is surgery. So what you need to remember in case of etiology right now is primary is generally due to autoimmune destruction or it could be due to congenital adrenal hyperplasia. Primary can also be due to adrenal hemorrhage or direct things that directly affect the gland. So it could be trauma, it could be infection, it could be surgery. Same will go for secondary. Most common cause for secondary is infiltrative diseases like sarcoidosis and hemochromatosis. Apart from that, trauma, infection, surgery, same thing. So we have hemorrhage and infection. You can think of it as in trauma or surgery, right? Tertiary, it is you have to remember only the exogenous steroids. Then it is surgery, trauma, etc. for tertiary as well. So these are the primary causes for primary, secondary, and tertiary. For primary, it is autoimmune. For secondary, it is infiltrative. For tertiary, it is exogenous steroids. That covers our introduction and epidemiology. Now, in case of epidemiology, we will be including prognosis as well, but this condition does not have a lot on prognosis. So, in case of prognosis, untreated patients have high mortality. If a patient with primary adrenal insufficiency is coming to you, the patient is hypotensive, you keep giving the patient normal saline and it is not responsive, then the patient will die. So, mortality high if it is untreated, but if you treat it right, if you treat it adequately, then the mortality is not that much and they can have a normal lifespan. This thing will change according to each and every single disease. So, in case of Friedreich's ataxia, in case of myotonic dystrophy, lifespan is reduced. Most common cause of death is cardiac issues. These are the kind of questions you will be seeing in step 2. They will give you a scenario describing myotonic dystrophy, then they will ask you what is the most common, what is the most likely cause of death in this patient later on. That is how the question will be. Now, the pathophysiology. Pathophysiology of primary is that there is no cortisol because the cortex itself is damaged. So there is no cortisol, but there is normal functioning ACTH and CRH. So if there is no cortisol but intact ACTH, what will happen in primary is that ACTH will go up, CRH will go up. Whereas in case of secondary, ACTH is low despite normal cortex and hypothalamus. So in case of secondary, the gland is normal, the hypothalamus is normal, the pituitary is affected. So CRH from hypothalamus is high, but pituitary is not secreting ACTH. That is why ACTH is low. ACTH is low, so cortisol will also be low. That is how you differentiate from primary to secondary. In cortisol deficiency is present in all three. But in case of primary, cortisol is deficient because the adrenal gland cannot produce it. In secondary, it is deficient because the pituitary is not sending the ACTH, and in tertiary, it is not there because there is no CRH. Now, in case of secondary and tertiary, RAS axis is preserved. This is the most important thing from today's discussion. What is the core difference from primary, secondary, tertiary? Primary RAS axis is gone. Why? Because cortex itself is damaged. Cortex is the thing that is producing mineralocorticoids. If the cortex is gone, then glucocorticoids, mineralocorticoids, androgen, all of them will be gone. But if it is a secondary deficiency, secondary insufficiency, and the gland itself is normal, then what will happen is that due to hypotension, kidney will be sending signals to adrenal gland through renin, angiotensin, aldosterone system. And since the cortex is normal, the aldosterone is still being produced and the aldosterone will be released. So in case of secondary and tertiary, the only deficiency, true deficiency, is of cortisol, not of mineralocorticoid. That is the essential difference. So we now know what is adrenal insufficiency, what is the etiology, what is the pathophysiology behind that, and we can guess a little bit about symptoms based on this. We know that mineralocorticoids are responsible for maintenance of sodium and volume status. We know that much. We know that cortisol is responsible for maintenance of glucose levels. So if there is a true glucocorticoid deficiency, you will be seeing uh, low levels of glucose as well. Apart from that, presentation is not that much characteristic. So how does a patient of adrenal insufficiency present? The common presenting signs are these. These are the most common presenting signs that you will be given in your questions. Hypotension, altered mental status, anorexia, nausea, vomiting, weight loss, fatigue, and abdominal pain. These are very non-specific signs, very much non-specific signs. Any condition can cause it. But this is the thing. Other conditions have specific signs and symptoms, excluding these common signs and symptoms. Whereas adrenal insufficiency has only this. So what you need to do is when you see hypotension along with nausea, vomiting, and abdominal pain, you have to think of adrenal insufficiency. Basically, this is what having a high index of suspicion means. You see hypotension, you see nausea, vomiting, and you see abdominal pain. This prompts you to think about adrenal insufficiency. That is having high index of suspicion. Now, what else could be the cause for this? What else could be the presenting sign for adrenal insufficiency? Decreased libido, decreased secondary sexual characteristic. These are specific signs in women, which is due to lack of DHES production. This will happen only in women, not in men, because men generate their own testosterone through testes, whereas women have to rely on DHEAS. There is a little difference between DHEA and DHEAS. DHEAS is generated from adrenal cortex, whereas DHEA itself, just the DHEA, is generated in the ovaries. So, in women, what you will see is that there will be decreased libido, decreased secondary sexual characteristic, but only in primary, not in secondary, not in tertiary. Salt craving and orthostatic hypotension, these are more common in primary due to volume depletion from absent mineralocorticoids. So we've talked about it exhaustively already. Mineralocorticoids meaning aldosterone. Aldosterone maintains it causes salt and water retention. If there is excess aldosterone, it will cause salt water retention, causing hypertension. If there is no aldosterone, that means salt and water will be gone in urine. Instead, potassium will be retained. So, absence of aldosterone or primary adrenal insufficiency will cause hypotension, hyponatremia, and hyperkalemia. If you flip that, if you do hypernatremia, or not hypernatremia, but if you basically do hypertension and hypokalemia, then it is adrenal excess. That is adrenal excess. Now, signs of Cushing's may also be present in steroid-induced tertiary adrenal insufficiency. So what am I trying to say with this? we saw in this question that there were signs of proximal muscle weakness, right? Proximal muscle weakness. Proximal muscle weakness is one adverse effect of chronic steroid use. So, if some patient has been using steroids for a long time, they will start developing the symptoms of that steroid excess. One symptom of that is proximal muscle weakness. Another symptom of that is iatrogenic Cushing syndrome. So, we know that if you give steroids to patients, it can cause Cushing syndrome, right? So, what can happen in this patient? What is suggestive? The proximal muscle weakness is suggestive that this patient is taking steroids from a long time. So, what it is trying to tell you is that this patient's HPA axis is already busted. This patient is already taking exogenous steroids from so long that it is causing them proximal muscle weakness, meaning that this patient will develop the secondary or tertiary adrenal insufficiency if the steroids were stopped abruptly. So this patient cannot generate their own steroids. That is what it is trying to tell you by giving you this sentence. This sentence that weakness in proximal muscles, or it could be signs and symptoms Cushing syndrome. So it could be like stria or weight or anything else. That is suggestive that this patient has been taking steroids from a long, long time. And what will happen in that case is that uh, tertiary adrenal insufficiency happens because of HPA axis is already broken. I hope you guys know how the HPA axis gets broken by exogenous steroids. So steroids are being generated from the adrenal cortex, right? If you are giving steroids, then it will cause negative feedback inhibition of pituitary and hypothalamus. So that is how it causes secondary or tertiary adrenal insufficiency. That is how steroids cause that, right? So, signs of Cushing syndrome may be present in exogenous steroid induced tertiary adrenal insufficiency. Lastly, hypotension not responding to plasma expansion is a classic presentation that is tested on USMLE. You will see that in your step 1 and in your step 2 as well. If a patient is coming to ICU after undergoing any type of trauma or accident, but there is no clear signs of hemorrhage. The patient is hypotensive. You are giving patient normal saline. You have given 1 to 2 liters of normal saline, and the blood pressure has not changed at all. In that case, what you are supposed to do is give patient intravenous hydrocortisone, because this may be due to adrenal insufficiency, which could be primary, secondary, or tertiary. You don't know that yet, but that is the likely cause. But you will give those steroids only after you have ruled out infections. So you have a stem. In that stem, patient is hypotensive on presentation, temperature is normal, no evidence of immunodeficiency or no evidence of immunocompromise, nothing suggestive of infections. Now the BP is persistently low despite giving multiple boluses of normal saline. In that case, you give intravenous hydrocortisone. Hydrocortisone has glucocorticoid and mineralocorticoid properties both, so that is why we prefer hydrocortisone. Now, we talked a lot about presentation. We spent a lot of time behind talking about all of this. But these sentences are very small, because what your goal should be is that you have to have understanding, and in addition to that, you have to have a small list that you can see before your exam. So ideally what you should do is you should do two revisions of your notes. First after you finish your ULT, and second is right before your exam. Two reviews of your own notes are recommended. So if you make your notes concisely from the beginning itself, where you only have the information which you really need to see before your exam. So this is like that information that you have to remember, understand and remember. So you already understand this now. Now all you have to do is remember this. Salt craving in orthostatic hypotension is more common in PAI. Pigmentation is more common in primary. Decreased libido and sexual characteristic is due to DHEAS, more common in primary. You have to remember these things and you have to understand them as well. So this will be concise, but I have given you what you have to know in the background and you will remember it in their 20 years. Okay, great. So we were talking about evaluation and differences between primary and secondary. The evaluation is with, initially it is with ACTH and cortisol followed up by cosentropin. If ACTH is high, that means that pituitary is functional, so it is primary. If it is low, then it is secondary or tertiary. If we do cosentropin stimulation and there is no response, then it is primary. If there is blunted or minimal response or a good response even, then it is secondary or tertiary. The crux difference here is hyperpigmentation. Hyperpigmentation, you will see that only in primary, not at all in secondary. So the rest of the things, the remaining things will go on etiology section. That is how you make a differentiation whether it is primary or secondary. Treatment. Now, treatment is if the patient is taking steroids and the patient stopped steroids abruptly, then just resume the steroids. In case of tertiary or in case of abrupt cessation, the treatment is resumption of steroids. Primary is treated with exogenous glucocorticoids and mineralocorticoids as needed. So you give the patient hydrocortisone. The patient is stable on hydrocortisone. You do not need to add fludrocortisone on it. But if you are giving the patient hydrocortisone and the patient's glucose is normal, but the patient is still suffering from hypotension and hyponatremia and thirst, in that case you have to add fludrocortisone, because fludrocortisone is mineralocorticoid whereas hydrocortisone is glucocorticoid. I agree that hydrocortisone has little bit of mineralocorticoid activity, but sometimes it is not sufficient. So this treatment is on case by case basis. All right. Next, if there is minor febrile illness or a minor stress, what do you do in that case? You just increase the glucocorticoid dose by 2 to 3 times per day. Normal amount, increase it, double it or triple it without changing the mineralocorticoids for the duration of the illness or stress. Now, this is something that is not covered in UWorld or in MBOSS. Maybe it is covered in MBOSS, I'm not entirely sure, but this is a likely question that could come in your exam. So they ask you about what do you change in case of thyroid if a patient becomes pregnant. Similarly, could be if a patient is on primary adrenal insufficiency and is taking hydrocortisone and now is becoming pregnant, what do you do now? That is a likely question that could come. IV hydrocortisone if a patient is undergoing surgery, before the surgery. And lastly, adrenal crisis, because it is related. Adrenal crisis is treated with 2 to 3 liters of normal saline, and after that you give IV hydrocortisone. Correction of electrolytes and mild hyponatremia generally does not require treatment as it corrects, self-corrects. So only thing important for adrenal crisis is this sentence. Everything else is intuition. Patient with adrenal crisis will present with hypovolemia and hyponatremia and hyperkalemia. So what you will do is, first you will give the patient normal saline. You will give 1 to 2 liters, maybe even 3 liters. And if it is not improving, then you give hydrocortisone. You have to correct the potassium because potassium is more serious, but you do not need to correct salt because salt will self-correct as you correct the underlying condition. Similarly, in case of diabetes, we do not worry much about sodium. We worry mostly about potassium. So this is similar in that regard. So this is the underlying basic information that you need to know. Now we can go through the questions again. And I hope everyone will be able to answer these questions now.